Good morning, Ashik. Good morning, Dharani.
Good morning, sir.
Good morning, sir.
I looked, there's a bag of pressure cooker.
Good morning, David.
Morning, Gopal.
Good morning.
A lot of rain in Chennai, Madras.
Yes. Yeah, I saw the videos. My God, it is scary. It's worse than the last flood.
Correct. No, this one, absolute rain pouring down, and that one was
Yes.
breakage of some lake. So one
Yes.
clipping they showed one.
The storm is it's going up the coast. Yeah, I saw one apartment complex where all the cars were being washed.
That's
down.
right. One crocodile was really.
Medicine, my God. Scary.
Good morning, sir. Am I audible, sir?
Yeah. Good morning, Dharani Kumar. You're audible. Your presentation can be seen. You can start your presentation.
Yes, sir. So today's topic is about glenoid fractures and its management, sir. Just a minute, sir. So coming to scapular fracture is the rarest of all fractures. It constitutes only 1% of all fracture, along in which glenoid neck is about 25% and glenoid cavity fracture is about 10%. This fracture is uncommon because of its significant protection from the thoracic cavity and musculature, and also it has less scapular mobility.
So Dharani is having a problem with his connectivity. He'll be joining shortly.
No, it's okay, sir. Yeah, just a minute. Glenoid fracture is rim fracture and avulsion fracture is usually associated with dislocation, and anterior shoulder dislocation is in 10 in 1 lakh personnel, and usually is associated in contact sports personnel and also in military personnel. So glenoid fossa fracture is usually occurs in blunt force trauma and all with high energy. It occurs in 65% of males, and the average age is about 40 years. Usually it is involved in high energy mechanism, and it's associated with high rate of associated injuries. Most common is rim fracture with posterior dislocation. It constitutes about 75 to 85% of all glenoid fractures. Surgical involvement is in rib fracture, which is about 52%, clavicle fracture, spine, and followed by brachial plexus injury. Whereas medical involvement in the form of pulmonary contusion, head injury, pneumothorax, and vascular injury. So coming to the classification, IDP classification is the most commonly used classification. Here, 1A, it is anterior rim fracture, whereas in 1B, it is posterior rim fracture. In type 2, here we can see the fracture line passes through the glenoid fossa and exits laterally. Whereas in case of type 3, the fracture passes through the glenoid fossa and exits superiorly. In case of type 4, the fracture line passes through the glenoid fossa and exits in the medial border of the scapula. So in case of type 5A, it is a combination of type 2, 1, 4. That is, the fracture line exits in lateral border and also along the medial border. In type 5B, the fracture line exits through the superior border and also through the medial border. In case of 5C, it is a combination of all three. That is, it exits through the lateral border, superiorly, and also medially. In case of type 6, it is the glenoid fossa is severely comminuted. Coming to genetic classification, here in case it is for a rim fracture, in type 1, the fracture is displaced, but it has attachment in the labrum. Whereas in type 2, the fracture is not displaced much, but it is dissociated from the labrum. In case of type 3A, the labrum is dissociated, but the glenoid bone loss is less than 25% of the surface area. Whereas in type 3B, the labrum is dissociated, but the glenoid bone loss is more than 25% of the surface area. Now coming to AVO classification, 1-4 designates for scapula. F0 is for extra-articular fracture. F1 is for the single fracture through the glenoid fossa, whereas in F2 it is comminuted fracture. In case of F1.1, it is the anterior rim fracture. In F1.2, it is the posterior rim fracture, whereas in F1.3, the fracture line passes from anterior to the posterior fracture. In F2.1, it is a comminuted fracture, whereas in case of F2.2, comminuted fracture is associated with the central fracture dislocation. Since it is involvement of high energies, physical examination of the back is mandatory, where we should look for the skin aberration, bruising, and swelling. The movement of the shoulder will be painful, and also we have to look for the careful neurovascular examination, especially suprascapular nerve. Since high energy is involved, we have to take trauma series, which involves chest X-ray, pelvis biceps, and also cervical spine. So coming to the imaging, 3 views are mandatory. One is a true scapular view, which is also called as Gracie view, axillary view, and scapular V by view. Since the scapular anatomy is complex, we have to ask for CT scan along with 3D reconstruction, especially with the humeral subtraction view. A true view or Gracie view, as we know, scapula is oriented 30 degrees from the coronal plane. So we have to direct the beam 30 degrees from the coronal plane, so that we have to see for the true AP view of the shoulder. So in axillary view, we have to look for the coracoid, which is the lighthouse of the shoulder. So here we can assess whether the dislocation is anterior or posterior. Coming to scapular V by view, the beam should be directed along parallel to the scapular plane. So in CT scan, we have to ask for the 3D reconstruction with the humeral subtraction view, which is helpful in understanding the anatomy and the relations. So the measurement in X-ray, that glenopolar angle, which is an angle generated by the intersection of the two lines. That is, one line is drawn from inferior glenoid fossa to the superior lip of the glenoid. Other line is from superior apex of the glenoid fossa to the inferior angle of the scapula. If the angle is less than 20 degrees, then we have to go for operative fixation. Other, we have to look for the medial and lateral displacement. Here, if the displacement is between the most lateral point of the distal fragment and the most lateral point of the proximal fragment is more than 20 millimeter, then we have to go for operative fixation. Here, we have to look for the angle, which is an angle generated between the line along the proximal fragment and along the distal fragment. If the angle is more than 45 degree, then it differs the orientation of the glenoid fossa towards the shoulder joint. So we have to go for operative fixation. If the articular step is more than 4 mm, then we have to fix it operative. So an indication for operation is that if the glenoid angle is less than 20 degree, angulation is more than 45 degree, if the scapular height is shortened by 15 to 20 millimeter, or the translation is more than 10 millimeter, or in case of floating shoulder, that is a disruption of 2 out of 3 construct in the superior suspensory complex, also indicated for glenoid fixation. Particular to the glenoid, if the anterior glenoid is more than 15 to 20% involvement, or 10% in posterior glenoid, of the intraarticular step is more than 4 mm, then we have to fix it operatively. So operative approaches available are arthroscopic approach, which is minimally invasive. In case of anterior glenoid involvement, we can go for a deltopectoral approach, or in case of glenoid neck or posterior glenoid, we can opt for Judith approach, which is an interval between the infraspinatus and the teres minor. So coming to the arthroscopic approach, the options available are suture anchors, transiosseous or looped suture construct, percutaneous cannulated screws, or endobutton. Now endobutton is outdated because it's not in use and because of the higher rate of failure. For type 1 and type 2 fracture, as described by Sugaya, the fixation suture anchor fixation in the inferior and the anterior part. But the pitfalls in fracture fixation using Sugaya technique is that it involves only 2-point fixation, and it also give a complication of about lift off medially, hinging over the anchor plane, as shown in the pictorial diagram. So other technique propagated is that double row anchor fixation. Here, it avoids the medial lifting off, and also it involves larger contact area in fracture reduction, and it is used for only a smaller fragment. So in type 1, type 2 fracture, double row technique, first we have to look for the fracture and freshen the fracture site. As shown in the pictorial diagram, first we have to fix the suture anchor medially, and the suture loop will be anterior to the fracture fragment and the labrum. Then we have to take away the suture away from the vision by using a simple lasso technique. We have to take the suture behind the posterior capsule and the fracture, as shown in the diagram. Then we have to fix the same fracture suture, other end of the suture with the suture anchor laterally, so that the whole construct will be as shown in the diagram. One suture will be in the medial, other suture will be the lateral. The other technique propagated is that double row, double pulley anchor fixation, but it involves a complication of a suture burden and also suture management. In case of type 3 fractures, as we show, the fracture fragment exits superiorly. It involves a single fragment of superior glenoid fossa and also the coracoid. Here, the important structure that should be careful is that suprascapular nerve, which passes through the supraglenoid notch. For a type 3 fracture, first we have to freshen the fracture fragment. Here, then the next step is that subacromial bursectomy to look for the superior part of the glenoid. Then we have to retire the supraspinatus posteriorly, so that we could see the superior part of the glenoid. And we have to dissect the coracoid so that to avoid any injury to the major structures. The next step is that we have to, with the help of either cobblers or Weber's clamp, we have to hold the coracoid and manipulate it so that we indirectly reduces the fracture in the glenoid fossa. So once the fracture is reduced by manipulating the coracoid, you should pass the K wires from superior glenoid fossa to the inferior fragment, as shown in the picture. So this is the post-operative fixation of the type 3 fractures. So another jig that it's called a special glenoid jig. It can also be used for K-wire placement and also simultaneously reduction of the fracture fragment. It is similar to the collinear clamp in that is used in pelvis. So, but pitfalls in screw fixation is that the angle of fixation will not be perpendicular to the fracture line, and also the fragment is too small to hold any one screw. Usually, for the fracture fixation, it's advisable for 2 screws to avoid any rotational malformity. Here, since the fragment is too small, only one screw is will be held enough to fix it. But the fracture breaks while tightening the screw, since the fracture fragment is very small. So in case of type 4 to 6, open reduction is ideal. Here, either a traditional Judet incision can be used or modified Judet incision. That is, it is at a plane between the infraspinatus and the teres minor. In standard Judet incision, the incision will be from a superior and it will be passing through the medial border, whereas in reverse Judet, it passes superiorly and it makes an acute turn and passes through the lateral border. Here, it is used in the fracture is more lateral, and since gravity retracts the flap on the lateral position, and the angle of incision is more acute, and also it is less forgiving. The next step is that we have to retract the deltoid. It can also lift in place in case of extraarticular fracture or in case the fracture exists more in infraspinatus fossa. It should be lifted off to visualize the scapular neck or spinal glenoid notch, or if the fracture line passes through the scapular spine. So in case of classic Judet, the scapular fossa musculature is completely lifted off so that it gives a complete wide exposure to the scapula. So in case of modified Judet, there infraspinatus is not lifted completely, and the interval is just between the infraspinatus and the teres minor. So comparing the exposure, modified Judet has lesser exposure, whereas Judet and triceps release exposure gives a very good exposure, but fracture pattern may not require most of the exposure for accurate reduction. So in case of NIPO or fracture that can be indirectly reduced, modified Judets can be used. So in case of further exposure of the glenoid fossa, infraspinatus stenotomy is described by Garlich in 2020. So these are the areas of maximum fixation, that is through the scapular spine, lateral border and medial border, which has good found to be have good cortical purchase and also good bony stock. So complication of surgery involves axillary and muscular cutaneous and suprascapular nerve injury. Hardware complications such as loosening, impingement, or intra-articular fixation. As like in pelvis, since it is involved on much amount of muscle and dissection, heterotropic ossification in scapula is more common. So taking message. The vast majority of the glenoid fractures are bony Bankard's lesion. The glenoid fossa fracture consider indication for the operative intervention. So good outcomes can be achieved with appropriate fixation methods for the operative fracture pattern. Thank you.
Thanks, Dharnikumar. We will finish off the anterior shoulder revision talk, and then we'll have a discussion of these two together.
Yes.
Good morning, sir. Am I audible? Hello, sir. Shall I proceed? So starting with the second talk, multi-directional instability and revision in case of failed anterior instability. Starting off, we need to understand the definition of multi-directional instability. It has been discussed multiple times in the last 2 weeks over multiple talks, but even then, I'll just very briefly go over the topic. In introduction to MDI, The term was coined in 1980, and it signifies instability of the shoulder joint in two or more planes. It is most commonly due to loss of function of the static and dynamic stabilizers. Static being the articular congruity, the labrum complex, glenohumeral ligament complex, negative pressure between the humeral head and the glenoid. Dynamic being the rotator cuff muscles, long head biceps tendon, and the periscapular musculature. Coming to the etiology, it can be due to repetitive microtrauma and hyperlaxity problems. Repetitive microtrauma is commonly seen in conditions of overuse, especially in high demand athletes like volleyball players, overhead athletes like volleyball players, gymnasts, swimmers, etc. And generalized laxity can be seen in congenital defects and medical conditions like Ehlers-Danlos, Marfan syndrome, and joint hypermobility syndrome. Coming to the epidemiology, it usually peaks in the second and third decade of life, as this is the time period when the patients are most commonly prey to all these trauma and accidents. And it becomes less and less common after the fourth decade when the joint goes into initial stages of stiffness. And most commonly seen conditions are in sedentary female with poor muscular development. The history, they lack a clear traumatic event, with the main complaints being shoulder pain, which is vague and associated with overhead activities. In case of athletes, what they complain of is mainly the lack of strength or athletic performance, especially in swimmers and in overhead athletes. Shoulder instability also, it has to be examined using our normal protocols like the sulcus sign, where you give a longitudinal traction and observe for the sulcus below the acromion, more than 2 centimeters being significant. You check for the apprehension test and load and shift test as seen thus. Objectively, we can even score it using the Baton's criteria, using the criteria where the thumb is able to touch the volar aspect of the forearm, the little finger is able to make go beyond parallel compared to the dorsal surface of the forearm. The palms are able to touch the floor without bending of the knees. Knees and the elbows hyper extending more than 10 degrees. Coming to imaging also, imaging X-rays, what we usually see is that X-rays are normal. What we look for is any glenoid dysplasia, hypoplasia, humeral head anomalies, or any large bony defects. Also, MRI can be useful, especially in looking for patulous inferior capsule. If the capsule is too loose or redundant, that it does not provide any further stability, or if there is any associated Bankhart's lesion or any Kim's lesion, which is can be seen in the posterior labrum as thus between the glenoid and the labrum. Coming to the treatment, just one slide on it. Initially, if the patient presents with just pain without any episode of subluxation dislocation, you can start off with physio, strengthening of rotator cuff and pericapsular muscles. You can go for closed kinetic chain exercises also. And in case the patient has already had episodes of dislocation and repetitive episodes as such, then you can go for open versus arthroscopic, depending on which clinical profile the patient fits into. Coming to the main section, the revision for a failed anterior instability. Now, I could not find many articles dealing with this topic per se, but I did my best try to collect from various different articles, and wherever possible, I have added these article names and data in the slide, respective slide. Starting off, what is the definition? In this paper, Evaluation Management of Failed Shoulder Instability Surgery, one of the main review articles from where I got my data from, it is defined as recurrence of shoulder instability post-primary surgery of fixation or stability. The patients commonly present with either complaints of dislocation or subluxation. Pain is also another complaint that they present with. And the main feature that they talk about is the shoulder being non-reliable. They don't have confidence in doing the activities of daily living or in doing high demand activities to what they were used to. So as soon as you come across this failed condition, the question you must ask is, why has it failed? There are 7 different components which I'll be going into. First of which is, does doing the primary fixation or stability surgery in open or arthroscopic play a role? As per this paper here, they mentioned that recent literature does not differentiate between open and arthroscopic surgeries. Both have the similar outcome in stabilization success. Second is patient selection. Coming to patient selection, it has been noted that age and gender are important determinants in predicting possibility of patient returning with instability after the primary surgery. The recurrence rate of instability after surgery was associated with patients less than 22 years, male gender, and with time period more than 6 months between the index dislocation and the time of primary surgery. Clinical evaluation is much like the primary surgery also. That is assessment of hyperlaxity using objective and subjective scorings, apprehension relocation tests, rotator cuff functional status. Rotator cuff involvement after traumatic dislocation of the shoulder has a high incidence in patients over 40 years of age, with an incidence in the current literature ranging from 35% to 86%. So what about the neurological component? Undetected neurological pathology is an important compounding factor for recurrent instability or failure of the primary surgery. Conditions like the axillary nerve palsy is a common associated lesion with incidence of more than 40% across all age groups. Lesions of the suprascapular nerve also have been documented, but in much smaller scale. So when should we suspect a neurological component as the primary cause of the initial stabilization surgery? If the age, this data says that with every passing decade, the increasing likelihood of neurological anomalies causing a repeat in decreased stability is 1.3 times. So an age group 20 to 30 will be 1.3 times more likely compared to a 0 to compared to 0 to 10, and each decade will have more and more likelihood of increasing the chances of neurological palsies. Next is hematoma. A patient presenting with hematoma will signify that the causative injury that is giving rise to the instability is 4 times at a greater risk, because the velocity or the causative insult is more significant, or it's a high velocity injury compared to a normal. Any associated fractures, again, the logic being that associated fractures presenting with this will make it a high velocity injury, or the causative insult leading to the failure of initial stabilization injury is a significant trauma. Now, imaging techniques. It is important to know that more than 80% of surgical failures for instability are associated with bone loss. That is why assessing the bone loss, whether it is a humeral bone loss or a glenoid bone loss, it is extremely important. And that is also why Burkhardt and Vivier in this paper had emphasized on the bone loss to such that they have created some templates which we can easily understand. First of which is arthroscopic Bankart repairs give results equal to open Bankart repairs if there are no structural bony deficits. Second template is patients with significant bone deficits are not candidates for arthroscopic Bankart repair. Third template, contact athletes without structural bone deficits may be treated by arthroscopic Bankart repair. However, contact athletes with bone deficits require open surgery aimed at specific anatomic deficiencies. And the last one is, for patients with significant glenoid bone loss, the surgeon should consider reconstruction by means of Latarjet procedure using a large coracoid bone graft. So you can see how the presence of bone lesions or bone loss, whether on the glenoid or on the humeral side, can dictate management, and hence making imaging techniques extremely important. So how much is too much? According to this paper by Itoy et al., they say that 21% of the glenoid width, or 6 to 8 mm of the glenoid bone, is the significant cutoff, whereby more than this needs a bony procedure to be dealt with to return stability after a failed initial repair. Not only the size, but also the position of the defect, as seen here by the paper by Burkhardt et al., they say that in presence of initial surgery, in presence of engaging Hill-Sachs defect, the defect also needs to be addressed if not done so initially. That could be giving rise to the repeat of instability. Also, the glenoid tracking concept in presence of humeral bone loss also. So not only the position, the size and the location of the bone defects, whether on the glenoid or on the humeral side, plays a very important role. So those were the bony components. Coming to the soft tissue components. So this paper by Randley et al. Talking about the risk factors for recurrence after Bankart repair of a systemic review talks about lesions such as the humeral avulsion of glenoid labrum, the anterolateral periosteal sleeve avulsion, and the slap lesion playing a causative factor in leading to a failure after stabilization surgeries. Another cause is technical errors. Technical errors can be further divided into failure of correct assessment of factors contributing to instability and B, surgical errors. Incorrect assessment of fractures can be the failure in assessing the glenoid or the humeral bone loss. It can be incorrect choice of bony procedures or soft tissue procedures. And it can be due to technical failures that can happen during any surgery, which we must be prepared to face. For example, screw breakage, joint penetration, incorrect position of bone fragment, resorption or fracture of bone fragment. Coming to surgical errors, insufficient mobilization of soft tissue, insufficient soft tissue plication, decreasing the redundancy of the capsule, lack of bone block procedures in case of GBL beyond the critical limit, poor positioning of the suture anchor. If it is too medial, there can be a recurrence of instability. If it is too proud, there can be a early arthrosis of the joint. So positioning of the suture anchor is also extremely important. And coming to the last one, can be a recurrent of traumatic episode. So if the initial fixation strength was not adequate enough, the paper says that even a normal ADL, normal activity of daily living, can also lead to recurrent instability. This can be due to a primary surgical failure or the primary complaint of instability or the cause of instability not being addressed adequately. Or if the patient is just unlucky, then he can go into a separate new onset high energy trauma, which leads to this repeat failure. That coming to the treatment options for failed instability surgery. First is conservative management a viable option? The papers here say that initial management, at least for the initial assessment period, you give the sling for support, reduces pain, reduces inflammation, and evaluate the reasons for failure. Conservative management per se is advised only for patients with extremely low functional demands, with no associated complications, and in patients who are unfit for resurgery. As per this paper, evaluation management and outcome after failed traumatic anterior shoulder instability, surgical measures are the gold standard when dealing with recurrence after shoulder instability surgery failure. But the type of procedure and the technical tools to apply in each case must be carefully decided in order to avoid more than one surgery after the initial failure. So revision. In case of revision, what is it supposed to be? Should we go ahead with open or should we go ahead with arthroscopy? In these two papers, as you can see, it states that studies using arthroscopic procedures, the incidence of recurrence was similar for both the techniques, open versus arthroscope. So the recurrence rate after revision surgery was reported by Levine et al. As 22% more than the initial surgery. So it doesn't really matter if we go in for a repeat open or a arthroscopy procedure as a revision case, as long as we do a satisfactory job regarding this. However, you have to understand and you have to explain to the patient that the outcome of the revision surgery will not be as good, or to talk in numerical terms, it will be 22% less likely to be as good as the primary surgery, primary repair. Now, what are the decision-making factors? What do we look at when we go ahead and decide which procedure to use as a revision surgery? We look at the age, the activity of the patient, and the functional profile. The type of ligamentous lesions that the patient might have in view of his comorbid conditions. Capsule labral quality, the presence of glenoid bone loss or associated humeral bone loss, if it is more than the critical limit or less than the critical limit. The existence of an engaging Hill-Sachs lesion, if not previously addressed. So coming to the different techniques, one is the arthroscopic capsule labral reconstruction procedures. The advantages of going arthroscopy is that we can visualize 360 degrees of the circumference of the joint. There will be less scar tissue. It reduces the postoperative pain and reduces subscap iatrogenic damage. And it gives less restriction to passive ROM. In one of the papers, they mentioned this, especially in cases of swimmers, athletes who are swimmers, where passive ROM is an important factor for their sport. So if the patient is a swimmer, more than likely it will be better, as long as the surgery is going to be successful, try to go for an arthroscopic repair. Objectives in an arthroscopic repair must be to anatomically reduce the labrum. The inferior and posterior inferior capsule plication must be done, and extract the previous surgery sutures or anchors. You don't want to leave any previous surgery hardware in situ, and you want to give a fresh fixation as much as possible in the revision surgery. The position can be Beecher or lateral decubitus, depending on which anatomical pathology you're addressing. And the portals are also pretty much the standard, in which you can go the posterior viewing, and instrumentation can be the anterior. And in case you're addressing the posterior lesions like the Kim lesion, then you can view through the anterior also. Anterior labrum is to be mobilized. Inspection of the posterior inferior capsule must be done, especially like I mentioned, if it's a Kim lesion or capsular elongation, which addresses with the posterior capsule, then you have to make sure that the posterior inferior capsular labral complex has to be addressed. Capsular plication also has to be decided and performed after the labral and the capsular labral repair is done. In cases of open capsule labral reconstruction procedures, we have a specific set of indications. What are they? In cases of collision athletes, hyperlaxity patients, glenoid bone loss more than 15 but less than 20%, presence of anterolateral periosteal sleeve avulsion or humeral avulsion of glenoid labrum, and poor capsular labral tissue quality. In those cases, it will be more successful or safer, let's say, to go open rather than using arthroscope. Approach is using the standard deltopectoral approach. Separate the subscap from the capsule, incise the capsule using a capsulotomy, and visualize the labrum. Identify and remove the previous hardware and repair the labrum and the pathologies that need to be addressed. So in this paper published by Namsu Cho et al., they say that 68 to 74% show a good outcome at 7-year follow-up on revision with open surgery after a failed arthroscopic primary surgery. So what if there are bone deficiencies that need to be addressed? That is where these procedures like Latarjet and Bristow come in. Latarjet and other bone block procedures for anterior glenoid defect is mainly used for the glenoid and the humeral side lesions. The two major techniques that are used are Bristow's procedure, that is with the transfer of the tip of the coracoid and the conjoint tendon that is fixed upright on the anterior glenoid defect with a screw, and the Latarjet procedure that transfers the coracoid from the tip to the neck with the conjoint tendon and seat it on the anterior inferior surface of the glenoid. Again, the approach will be the deltopectoral. Steps are pretty much the same. Split the subscap tendon, expose the joint, and freshen the anterior inferior margin where you want to seat the coracoid. Make sure that the splitting of the subscap is done by upper 2/3 and lower 1/3 junction, and along the line of the fibers. You don't want to traumatize the subscap muscle. And freshen the bed before you place the coracoid, and make sure always to position the graft not too medially, because then it will lead to instability, and not too proud, because then it will lead to early arthrosis. That is extremely important. The outcome, as per this paper by Samuel et al., they say that after Latarjet and bony corrections, there is excellent restoration of shoulder stability. And there is a possibility of persistence of pain, however, in the shoulder, noted in some patients, causing some patient dissatisfaction. So we've talked about all these procedures. So what if even this fails? What if even Latarjet fails? What is our next step? That is where this comes in. This is our final line of defense. This is our Eden Hibernate. So it is more, as you can see in this review article, it's more than 100 years old. And it is a very interesting article to read also. Initially, when both these surgeons came and developed using the tibial tuberosity as the initial graft, which seated into the pocket. Now, what we use is the iliac crest taken from the bone piece taken from the iliac crest that is seating. Initially, what they did was a tibial tuberosity, but then due to the complaints by the patients, due to difficulty kneeling and carrying out the activities of daily living, it has been modified. So it has gone through multiple levels of evolution. And it's a very interesting article to read, especially now that since 2007, these surgeries, some are even being done arthroscopically wise. Capsulodesis and other procedures to address the humeral Hill-Sachs lesion. In case the defect is more than 40% loss of articular surface, use of osseous allograft reconstruction in younger patients can be advised. It helps in filling the defect, which is structurally very large, with osteoconductive material in an attempt to avoid prosthetic replacement. Remplissage can be done if the defect is less than 30%. Some papers even say less than 20% of articular cartilage loss. Okay, so we've given a rough idea. Now let's look at the numbers. What does the recent literature say with regard to actual numbers, data? So in terms of capsulolabral defects, they say that Rowe et al. Demonstrated Bankart lesion and capsular laxity to be the commonest cause of recurrence of instability. That is 84% and 83% respectively. Sisto et al. Managed 30 patients with failed arthroscopic Bankarts with open Bankarts with no recurrence of instability at 46 months mean follow-up. So that is one example where open can cover up for the failure of arthroscopy. In revision cases. Systematic review of 388 shoulders done in 2014 showed open Bankarts had a failure rate of 5.5 and arthroscopic Bankart had a failure rate of 14.7. However, the p-value was not found to be statistically significant in this case. In terms of capsular laxity, Levine et al. Performed anterior-inferior capsular shifts in 49 patients, reported success rate of 78%. For inferior laxity, the capsule is plicated and capsulodesis was done to prevent the redundancy of the capsule and to clear out the empty space. Closure of the anterior rotator interval was also another procedure that was done to counter anterior laxity. So the verdict so far is, with terms of arthroscopy versus open, the difference is still not that statistically significant. It depends a lot on the patient profile and the indications which we have to follow. Now, in terms of management of bone defects, it must be noted that glenoid bone loss must be addressed if it is more than 20% of the critical limit. It keeps varying depending on which paper we read, but usually on the safer side, like Shamsa mentioned previously, let's go by the basics that we follow. Keep it at 20% and that we'll follow with that. In presence of the humeral Hill-Sachs lesion, the threshold for glenoid bone loss management must be lower. Burkhardt et al. Managed 102 patients with more than 25% glenoid bone loss with open Latarjet and found recurrence in 5% alone after a mean follow-up of 59 months. Even arthroscopically, as done by Lafosse, where he did 100 patients of arthroscopic Latarjet, and he followed them up for a mean period of 26 months and showed excellent outcome after revision surgery. 91% of the patients had a satisfactory outcome. Eden Hibernate is a relatively fail-safe procedure where a tricortical iliac crest bone graft was used and it was placed in place of the anterior rim of the glenoid to act as a bony fixation. Even for this, Lund et al. Had approved the use of Eden Hibernate as a fail-safe method as a salvage for revision in failed Latarjet and was found to have an ideal technique with excellent outcome in 74% and recurrence only in 12%. These numbers might not be very impressive, but as you go through papers, you see that 70% is a very good success rate for these procedures. Most important factor in doing a bony procedure for GBL management is to optimize the fixation of the graft. Like I kept mentioning, 2 medial, there'll be recurrence. 2 lateral, and there'll be early arthrosis. So positioning the graft is extremely important. If the humeral Hill-Sachs lesion is more than 20%, it plays a vital role in causing recurrence or instability, and it has to be dealt with bone grafting or derotation osteotomy or remplissage. Excuse me. Bone grafting is done if the Hill-Sachs lesion is more than 40%. It can be done, ideal procedure for younger population with no degenerative changes and good bone quality. Remplissage also, literature says that McCabe et al. Evaluated 31 patients of whom 11 had remplissage in addition to anterior stabilization and found that 7 of them had excellent outcomes. So what is the take-home message? What is the conclusion? So Gold standard is mainly surgical. Reasons for recurrence has to be thoroughly evaluated so that the repeat does not happen. Clinical evaluation, radiography are paramount in order to identify what caused the failure. Bone loss and soft tissue quality has to be meticulously measured and addressed in the revision surgery. If it is a small bone loss, anterior capsulolabral reconstruction plus minus remplissage can do. Major bone loss, bone block procedures must be done. Hill sacks more than 30%, fill with graft. Now, take home message throughout the procedure, what you have to understand is results of the revision surgery is worse than the primary and degrades if further surgeries are required. So it is absolutely imperative to get it right the first time. So try to avoid the case of resurgeries and do the best possible job uh, for the revision. Which brings me to my doubt also, sir. Sham sir, hello.
Yeah, tell.
So my doubt is, the entire presentation I found multiple papers saying stepwise, like you go scopy and then you revise open and then you go bone and then you go eat and hibernate, the stepwise. But in case a patient comes back and in view of this sentence that is there on the screen, because further surgeries just degrades it more and more, can't we just skip the open part and directly go for a bony fixation if addressing everything and go for a Latarjet straight away instead of revising a arthroscopic Bankart with an open Bankart and then going for another Latarjet? That is
that they see many a times we cannot rely on what the Western literature says. We have to stick on to what is best for our population, because there are more economical concerns,
yes,
and that has to be taken as a priority here in Indian scenario. Whereas in Western scenario, they tend to go as per the literature, because if in case there is a medico-legal proceedings, then you have to put forth the literature as an evidence as to why the surgery was done. Like the Workers' Compensation Act and all strongly insists on going by the literature review and the data. It doesn't hold good in India.
Yes,
so that's the reason there is a variation in the treatment protocol.
Yes, sir.
Yeah, fine. Now, there are two talks which have been discussed. One is a glenoid fracture. The other one is a revision of failed anterior instability. Now, glenoid fracture per se, as Dharani Kumar had classified here, type 4 and 5, no second thoughts about it. You have to open up and fix it. But this type 1, 2, and 3 is the one which is very important. You will come across these cases, and don't straight away jump into doing a Latarjet for these cases because you saw a fracture. You have to quantify whether the glenoid bone loss is significant or not. But whatever it is, this bone is viable bone. So always the primary measure is to try to fix the bone back to its native structure. That's where Sugaya has classified this glenoid bone loss into the percentage of loss. Now, if the glenoid bone loss is less than 12.5% of the entire glenoid width, then it is considered to be a small portion, and you can actually fix it using a suture anchor technique. And in that suture anchor technique, any configuration holds good as long as you get the congruity of the bone onto the articular surface. That is very important. So here, since it is a small bone piece that is less than 12.5%, you can actually pass the suture through the bone and fix it up, and it holds good. That is good. Anything between 12.5 to 25% of the glenoid bone loss is a big fragment, and that has to be stabilized both in the anteroposterior direction as well as the mediolateral direction, so that there is no overlap or overhang of the cartilage. Now, this is where Sugaya's technique is very, very important, because he places an anchor inferior to the bone and make sure that he ties the suture inferior to the bone along the capsule and the labrum, so that there is no shift in the bone block. And then he fixes it by passing another suture through the bone, not into the bone, all around the bone, and fixes it. And here you can either use a single pulley technique or a single row technique or a double pulley technique. It depends upon your comfort, but generally using a double row will be very difficult in a glenoid, because the bone substance is very small, and the economical factors also. If you're able to achieve that with a single row repair, that's good enough. In the first type, which is less than 12.5%, where you pass the suture through the bone, it is not the bone repair that matters. it is a capsular tightening that matters. So you have to reinstore the inferior capsular shift and make sure that the resting tension in the capsule is restored. So in these two types, that is type 1 and type 2, make sure the resting inferior capsular tightness is restored with the same technique which we use for Bankart repair, that is a capsular shift.
Yes.
Type 3 is one where it's more than 25%. And here we will have to think about the various armamentarium which we are having, which means we can either fix the bone fragment with the screw, we can use cannulated screws, we can use adjustable loop endo buttons, or we can use fiber tapes. It depends upon the various ease and availability of the instruments that you have. But what I would generally suggest is the presence of a fiber tape which does not cut through the bone, because we don't know whether our screw placement is optimal as compared to open technique, and hence the screw itself may actually burst through or crack the native bone, and if that happens, it's a disaster. So here we have the fiber tape which can be looped around the bone fragment, and it can be brought back onto the posterior aspect of the glenoid and tied effectively with a tensioner, something similar to a fiber tape fixation for an arthroscopic Latarjet. But in this case, it's not an arthroscopic Latarjet, it's just a bone fragment which you're fixing it, and it usually holds good, and it also prevents damage to the native bone fragment. So these are the methods which can be used to fix a glenoid. And whenever you try to fix the native bone in case of an acute trauma, 99.9% it heals well, and it becomes congruous, and sometimes the bone also grows because of remodeling. And the fixation of the bone is important, and equally important is restoring the resting tension. So make sure that it can be done for only up to type 3 fractures. Anything above type 3 which is huge enough, then you have to open up. We have no other options. So that is for the glenoid aspect. In the revision cases of failed anterior shoulder instability, what is the need to discuss about MDI? Because people don't understand the fact that the most important anatomical risk factor for failure of instability, apart from bone loss, is the capsular laxity. We do not give importance to the capsular laxity even while we are trying to examine the patient. We find that the sulcus is positive, but we don't know the significance of this laxity, because this is one single anatomical factor which can lead to failure in the absence of a bone loss. So always make sure when you're repairing, when you're doing a Bankart repair, as I told you, the capsular shift is restored, the capsule is tightened, capsular imbrication is brought about with your procedure. Now, when you fail to do that, then yes, especially in case of overhead athletes or people who are involved in throwing sports, yes, chances of failure is very, very high. Glenoid bone loss, we have discussed plenty. I think we must be experts in assessing glenoid bone loss by now. It all depends upon whether it's a erosion or a bony Bankart. If it is a glenoid erosion, whatever methodology that's been explained, that is the glenoid tracking, glenoid index, critical bone loss, holds good. And as per Ortho 1's protocol, we switch over to anything over 25% bone loss, definitely a Latarjet. Anything less than 25%, in case of a normal population, we can do an arthroscopic Bankart repair supplemented with remplissage. If the patient is a high demand person, or an athlete or policeman or a military or a high-end labor, then we directly go for a Latarjet, because Latarjet has got a less recurrence rate. If it is, we are not really keen on the 13.5% critical bone loss, because our spectrum of treating Latarjet is much higher, which means even with the 25% bone loss, we directly switch over to Latarjet. So we are not really keen on the critical bone loss. Now, we have to keep in mind these additional procedures like Eden Hibernate, and then using the lateral end of the distal clavicle, even the malleolus, or even the spine of the scapula, is in fact a very good option when you're trying to revise. Because in revision, it is majority of the cases, it's the additional bone loss which is the contributing factor for redislocation, and the capsule still holds good. The capsule will be viable. So in such cases, preparing the capsule very well and reinstating the bony architecture in the form of additional autographs like the spine of the scapula or the Eden Hibernate can make sure that you can reproduce near normal results, but we are yet to wait for the outcome measures from other surgeons. But right at present, these free bone graft transfers are crucial, and they may tend to replace Letarge. The main reason is in Letarge, we are actually violating the subscapularis.
Yes, sir.
If you're doing arthroscopy.
Yes.
Second thing is Indian coracoid, no, always troublesome. Letarge is technically more challenging procedure than an arthroscopic free bone graft procedure. If you do not procure the right graft and if you do not place the screws properly, then you're in a big trouble. So I think we will come across a lot of these free bone graft techniques in future, and this has got a good scope. So we have to capitalize on this technique.
Yes.
So always when you're coming across a patient with instability, assess first whether the patient has got a capsular laxity or not. If there is no capsular laxity, yes, go ahead with assessing the other anatomical risk factors like the patient's age, the patient's activity level, and then the bone loss. So if we go by this protocol, I think we will succeed in getting a good, successful primary repair.
Yes, sir.
Shyam, is it that lateral end of clavicle coming up in a big way in the place of Letarge bone block procedure?
Sir, the allograft, sir. Not
I say not
autograft.
a autograph.
Allograft. Yeah. Well, the autograft, we take either the iliac crest or the spine of the scapula. The rest of the things like the malleolus and the lateral end of the clavicle is an allograft.
Mhm.
Good morning, sir. Is my screen visible, sir?
Yes, Jason. Proceed.
Good morning, sir. We're presenting about posterior instability of shoulder, mainly focusing on clinical and radiological diagnosis. So, isolated posterior instability is reported as being the least common of all the glenohumeral instabilities, representing around 2 to 10% of all the cases. So, it is more challenging than anterior instability because the structural characteristics ranging from incompetent capsular complex, glenoid dysplasia and retroversion makes its diagnosis and classification and treatment more difficult. So clinical assessment is the history and the clinical presentation where the limb so the clinical present so the clinical presentation is the attitude at the time of injury, that is in flexion and direction position of the shoulder, and it varies from pain and apprehension and leading to positive jerk and dryer test, and also it can also represent as recurrent subluxation and dislocation, and usually this can be reproduced with provocative manuals. So the first image here is the load and shift test, where in posterior instability it will be the posterior load test will be positive. This is the jerk test, where the arm is held in abduction and the elbow inflection, and it is taken to range of motion. It is adducted around again against the chest, and any instability posteriorly is positive. So next is Kim test. Kim test is almost the same as jerk test, and here the arm is abducted and it is taken through the range of abduction around 45-degree diagonally, and axial load is applied posteriorly so that the posterior subluxation is recreated. So there's a concept of functional shoulder instability where it is due to the pathological activation of scapulothoracic and rotator cuff muscles, and it can be positional functional shoulder instability or non-positional FSI. Functional, it is either during the movement of the arm, predominantly in flexion and internal rotation, or non-positional with the resting position. Usually, the non-positional will is associated without structural deformities, but over a period of time, it can lead to the erosions. Structural instability, it can be either because of posterior blanket lesions or a capsular labral insufficiency due to repetitive microtrauma, glenoid bone loss, or a reverse Hill-Sachs lesion, leading to recurrent episodes of instability with arm in the rotated position, that is flexion and internal rotation and axial loading. Other structural changes which deserve special consideration are glenoid dysplasia and retroversion, since they lead to failure of soft tissue procedures. And this is discussed detailed in the further slides. One more important consideration is the patient's ability to willfully control the instability episodes. That is the distinction between the voluntary and involuntary group of people. And these voluntary group might be because of psychological or affective disorders, and usually have poor results regardless of the technique. So voluntary and involuntary dislocators that history becomes very, very important. Coming to imaging, it is the conventional X-rays with striker notch view, axillary lateral view showing the reverse Hill-Sachs defect, the humeral head, and the west point axillary view showing Bankart defects on the posterior glenoid ring. Coming to CT, it has been discussed extensively. This is the CT in parasagittal view or the end-face view, and the best fit circle method is taken, and the defect is calculated as a percentage, where it is D by the entire total surface area of A into 100. So this is the paper in 2015 by Moroder et al. In American Journal of Sports Medicine, and they found out different angles in the CT to calculate the defect and its influence on guiding the dislocation. So first figure is they have recreated the best fit circle with the remaining humeral head, and B, it is an alpha angle. So alpha angle is between the anterior and posterior defect margin, and this is beta angle. This is it is the angle between the bicipital groove and the anterior defect of the margin, anterior defect margin. And gamma angle, it is between the bicipital groove and the posterior defect margin. And delta angle, it is between the posterior defect margin and the posterior glenoid ring, this angle. And epsilon angle, it is the angle between posterior defect margin and the anterior glenoid ring. So what they found out was the discriminatory power of the alpha and beta angle was lower than the power of the gamma angle, because even though the defect is a larger size and non-critical localization, that is, even though the defect is of the larger size, its inability to engage in the posterior glenoid rim is not determined between the alpha and beta angles. Or at majority of the times, it might not reach this posterior glenoid rim, and therefore this gamma angle seems to be clinically relevant measurement. And a critical gamma angle above 90 degrees is considered significant, and it is it usually, majority of the times, usually leads to an engaging lesion. However, there's a drawback that even with the use of this gamma angle, exact cutoff value to distinguish between the engaging and non-engaging defect with posterior glenoid rim cannot be determined, since the degree of interrotation varies inter-individually. So this is the same Hill-Sachs lesion. It is from the bicipital groove to the posterior defect margin. Another important factor is the glenoid retroversion, and it is determined using the Friedman method, where it is a tangential line along the axis of the scapula, extending up to the medial border of the scapula, and a perpendicular line is drawn. This is the green line, perpendicular, and a tangential line drawn connecting the anterior glenoid and the posterior glenoid rim, and the angle between these two is the glenoid retroversion, and is considered normal below 10 degree with the setting of posterior instability. So this is the article published in 2000 in skeletal radiology. So they defined different types of morphological changes in the glenoid in the axial CT, and they described the lazy J sign of the which shows rounded glenoid deficiency, and also a triangular delta bone deficiency. So the same thing represented in the CT images. And other important factor was glenoid dysplasia. This is the CT image showing glenoid dysplasia, which eventually causes more retroversion of the glenoid and posterior centralization of the humeral head because of the defect. MRI is an important diagnostic modality to identify the soft tissue injuries like capsule labral and other structures. So this is an MRI image showing the posterior labrum tear. So this is the illustration of the Bankert lesion, where the posterior labrum is also detached, and also there is avulsion of the scapular periosteum. So this has to be differentiated between the Palpsa lesion, which I'll describe in further slides. And as described before, this is an axillary view showing the reverse Bankert lesion. And after reduction, we can see the contained reverse Ilsachs lesion. So, and in few cases, however, being rare, the posterior instability might be associated with this FAGL, that is posterior humeral avulsion of the glenohumeral ligament. So this is the schematic representation of the avulsion and the MRI images. So this also causes the humeral head to subluxate posteriorly, and this is a sagittal image where we can see the band of inferior glenohumeral ligament retracting inferiorly. One more variant is the Kim lesion. So this is the figure A represents that marginal crack, also called as Kim lesion in the axial images, differentiated between the posterior labral tear. So Kim classification of posterior labral tear is type 1, 2, 3, and 4. 1 is incomplete detachment, 2 is the Kim lesion. This is the schematic representation, 2 is the Kim lesion, and 3 is contralabral erosion, and 4 is flat tear. So this image shows a labral tear along with a cyst in the posterior aspect. This is another variant where the CT scan shows a Bennett lesion, which is linear calcification adjacent to the posterior osseous glenoid margin. And this is the Palpsa lesion, which is the periosteum of the scapula is stripped, but it is intact. In Bankert lesion, there is a break here. And the proposed injury mechanism in Palpsa is the continuous impingement of the humeral head on the posterior labrum and capsule during an episode of subluxation or dislocation of the shoulder. So this is a study by Yu et al. In 2021, where they described 3 different morphological changes in the glenoid, and they described the glenoid being concave, flat, and convex. So this is usually associated with the dysplastic glenoid with the triangular deficiency. And they also determine the term concentricity and eccentricity. So how they determine this is they have taken the insertion points of the subscapularis and the infraspinatus. A line joining the insertion points of subscapularis and infraspinatus is drawn, that is line A. And line B is along the long axis of the humeral head. And the best fit circle is drawn corresponding to the articular surface of the humeral head. And this line is the force vector, resultant force vector is acting along the center of the glenoid. Whereas in the posterior capsular redundancy or posterior capsular lesions or a Bankert lesion, what happens is there is this causes the humeral head to rotate internally, and the resultant force acting more posteriorly. So this is the concentric force vector and the eccentric force vector. This is a study conducted. This is proposed by Philip Moroder in 2017, and he classified the posterior instability as ABC classification. So this is a very comprehensive classification. So I'll explain it. So it is either type 1 or 2. In type 1, this is classified as A1, A2, B1, B2, C1, C2. A1 being the posterior subluxation type. So here the humeral head translates posteriorly over the glenoid rim and spontaneously gets reduced into the normal position without any bony or soft tissue defects. So this is usually associated with a minor or moderate trauma, and with the sorry, sir, Wi-Fi got disconnected. So immobilization in internal rotation is shown to improve posterior labral reduction after a sustained posterior labral. Sir, am I audible?
Yes, Chetan, but I'm not able to see your presentation.
Sir, connection is unstable. One second, sir. Yes.
Yeah, now we can see the presentation. You can start.
Yes. So as I was describing, this type A1, that is subluxation group, is not associated with structural deficiencies, and main treatment is conservative or immobilization and interrotation, because this in interrotation position, the results have been found to be good, and surgery is usually not recommended and can be considered in young high demanding patients. So coming to A2, here there is obvious dislocation, and it is dislocates posteriorly, sustaining reverse hill sacks and reverse Bankert lesion, leading to a locked situation. So this is associated with an high trauma, usually in the arm in that provocated position, that is flexion and interrotation. Or sometimes really it can be because of pathological muscle contraction during seizures or electrical accidents. So coming to the treatment part, just highlighting the principles. So it can be closed or open flexion can be attempted. So the C image shows the reduced humeral head onto the glenoid with a significant reversal sac lesion. So as we described previously, with a reversal sac lesion with gamma angle of more than 90 degrees is more significant and critical, and can be treated with bone grafting or soft tissue coverage procedures. And posterior glenoid rim fractures can be treated arthroscopically using anchors or screws. And very least majority, it can be conserved where there is no bony defects or a soft tissue defect. So now it is B1. It is functional dynamic posterior instability. So here there is a pathological activation of the rotator cuff muscle along with the periscapular musculature leading to posterior dislocation. And it can also be associated with structural deficiencies such as hyperlaxity, posterior capsular redundancy, or flattened glenoid concavity as described previously, and or increased glenoid retroversion due to dysplasia. So it can be overcome by strengthening the external rotators and also the periscapular musculature, because this is due to hypoactive external rotators and in a few cases because of scapular dyskinesis. And hyperlaxity is also should be evaluated because this is a dynamic instability, and it is evaluated by means of Bitten score or a Troyer test, Salcocine and Gaggy hyperreduction test. So B1 conservative is the first modality of treatment to normalize the muscle activation pattern, focusing on scapula and also rotator cuff, and is mainly activating the external rotators. Surgical treatment is not warranted in this group because it usually fails to restore the stability and also causes limited function in the patient post-op. Next is B2. Here there is a structural damage showing the posterior Bankart lesion along with reversal sacs. This can be aggravated with structural and functional deficiencies as described here. Structural deficiencies being the capsule labris and issues, and also bony issues like concavity and retroversion with glenoid dysplasia. And here functional tests like jerk, Kim, and load tests are highly positive. So surgical treatment is mainly focused on the repair of soft tissue or bony coverage, again with the ILSACs being with the gamma angle being more than 90 degrees. And in few cases where it is painless and a dynamic posterior instability, physio can be the modality of treatment. So summarizing, B1 is a functional instability and B2 is a structural instability. So B1 modality of treatment is conservative and B2 modality of treatment is surgical. Coming to the last part, that is C1. It is constitutional static instability or acquired static instability. So C1, the pathomechanism is poorly understood. It can be due to multiple causes, either because of force imbalance or scapular malpositioning, leading to eccentric loading of the joint, as shown in the picture, where the humeral is loading posteriorly, or it is because of retroversion. So here it is a case of glenoid dysplasia, where there is convexity of the glenoid and also associated with retroversion. And sometimes the patient can be asymptomatic, and hence surgery here is to have a balance along the shoulder. So it is attempted to recenter this humeral head back to the glenoid. And sometimes surgical treatment can also be used where there is anterior soft tissue release with the posterior capsulorrhaphy or bony procedures, and it is associated with limited success. Coming to C2. So this is associated with structural defects with reverse heel sacks and obviously decentered joint. And in children, it might be because of brachial plexus injury. The typical police defect where the humeral head is in too much of internotation due to and causes as the disease is progressing, it leads to internotator contracture and rotational imbalance, leading to subluxation and deficiencies causing posterior glenoid rim dysplasia. So over a period of time, because of the continuous position in continuous dislocated position, it can lead to osteoarthritis. So and hence treatment is surgical, restoring this articular surfaces using bone graft or soft tissue procedure, and and occasionally rotational osteotomy can also be used in chronic cases of reverse heel sac lesion. Advanced OA replacement is a treatment of choice, and if it is associated with loss of muscular control, it can be constrained using reverse shoulder also. And if it is associated with the glenoid bone loss, bony block procedure, and posterior open midge glenoid osteotomy can be a treatment. So why this ABC is significant? It is comprehensive classification with clear distinction criteria and therapeutic relevance. So this is the first classification where they described treatment according to the dislocation pattern. And they also described different subtypes can overlap, like this functional dynamic instability overlaps. B1 overlaps with B2, the functional dynamic with the structural dynamic. And if not addressed at particular point of time, the progression from one group to another is possible. Like A2, the dislocation will lead to the structural B2 and then to C2. So as described before, in type 1, this category, conservative treatment is attempted, and surgical treatment for the type 2. And this has been again proved, and this is the study in Gesta 2021 by Stepam et al., where they had 29 shoulders of type A posterior shoulder dislocation, and they found out that conservative treatment is a viable option, especially in patients with centered joint lower gamma angle that is less than 90 degree or an old age. So this is how they found out the centrality. So this is the anterior and posterior glenoid rim margin, and then perpendicular and drawing. This is the center of the glenohumeral, the humeral head. And if this distance is reduced, they found out that the centrality is shifted back to the posterior, and this is the normal gamma angle which have been discussed. So this was the study including 29 shoulders, and they found out that redislocation was present in 21%, and 31% underwent surgery because of persistent symptoms, and found out higher gamma angle more than 90 degree was the reason in the failure group. And also this higher gamma angle eventually led to development of osteoarthritis also. And they concluded that the centered joint with low gamma angle has a good prognosis in conservative management. Take home message, sir. So posterior glenohumeral instability demands high degree of clinical suspicion, because long-standing cases of cuff tear also can have a similar presentation. And classification should consider biomechanics, whether it is functional muscular imbalance or structural changes, and the intentionality, whether it is a voluntary dislocator or a non-voluntary dislocator. It can have a very clinical presentation and different structural alterations ranging from capsular labral lesions and bone defects to glenoid dysplasia and retroversion. And physiotherapy is mainly focused on the periscapular muscle re-education, and external rotation strengthening is always the first line of treatment. Treatment should not only include reversal effect size, but also the defect location, and hence the gamma angle has outruled those alpha, beta, delta, and epsilon angles. And the bone block procedures are indicated in recurrent cases of instability after the failure of conservative treatment. Thank you, sir.
Now, this is a very important topic because in anterior shoulder instability, the clinical diagnosis itself is good. It holds good. So all apprehension, everything will be positive, and you have a very high clinical suspicion for anterior shoulder instability. But whereas for a posterior instability or posterior labral tear or a paralabral cyst formation, we are highly dependent on radiological parameters to validate our clinical diagnosis. And that's where clinical examination is very, very important. And keep in mind, the anatomical factors are very important here, leading to posterior labral tear or posterior symptoms. The most important thing is, as we all know, the version, the Glenoid version. It is proven that the Glenoid version is it's more retroverted in patients with posterior labral tears and instability. But the significance of the anterior Hill-Sachs is also very, very important. So if it is, if we find that the anterior Hill-Sachs lesion is significant and has a propensity to engage, especially in presence of capsular laxity, then we may have to do something called the McLaulin's procedure. The subscapularis stenodesis onto the Hill-Sachs lesion, which people tend to call it as a reverse remplissage. That, along with the labral repair, will hold good. But if the retroversion is more than 15 degrees, then an osteotomy procedure is validated. We may have to do a posterior Weber's osteotomy and open wedge osteotomy with a bone graft to neutralize the Glenoid version, along with labral repair if there is a labral tear. So keep in mind, it is not just a simple labral repair or a reverse remplissage. There are many factors which are associated with it. We don't see the amount of posterior instability is not as frequent as anterior because of the arm position. Day-to-day activities involves a lot of external rotation rather than internal rotation, and that is the reason why we see more of anterior dislocation. But do not miss out on young patients, maybe around 20 to 40 years of age, complaining of postero-superior joint pain during activity level. This is a classical complaint the patient presents with. And if you have any patient with this kind of a complaint, always give keen importance to the posterior labrum and do all the necessary tests to make sure that the posterior labrum is normal, and also radiological parameters are needed to validate our suspicion. So anyway, Sunday we are having this radiological aspects of joints, and there also we will be discussing in detail about mainly about the posterior labral tears, because we have discussed enough about anterior labral tears. Posterior labral tears and the diagnosis can be discussed a lot with the radiologist on Sunday. Any questions? Now, if you don't have any questions, sir, can we end the meeting, sir?
Yeah, please. And normally we have the third talk, either a plasty or a spine, so that everybody is interested. I just wondering why all three are sports medicine. Just a thought. Thank you. You can wind up the meeting. Thank you.
Good night.
Sir, we'll look into it, sir. Thank you, sir. Good night.
Good night, Shiv.